The meeting is being recorded. So as I said, I'm Professor Jenny Gallagher. So I wear a number of hats at King's College London, where I'm Newland Pedley Professor of Oral Health Strategy. I'm an honorary consultant in dental public health, and I've got a range of international duties, including being Dean for International Affairs. So it's GOHIRN is very much part of my passion and matches with my range of interests. And so today it's a particular pleasure to welcome Dr. Margaret Wandera, who's going to speak to us on infant oral mutilation, an overview of the practice in Uganda. And just to share with you a little bit about Margaret, she's a qualified dental surgeon. She graduated from Uganda, and then she later obtained her master's in science and her PhD from the University of Bergen in Norway. And there her PhD looked specifically at mother's oral health. And then that really opened up the whole aspect of the oral health of Ugandan mothers and oral health related behaviors which impacted, of course, on their children. So she's involved in oral health promotion activities within the country. She's a member of IADR and of the AMER region. She's been part of task forces in the Global Oral Health Interest Group, a member of the Institutional Review Board, College of Veterinary Medicine, Animal Resources and Biomedical Sciences at Makerere University in Kampala in Uganda. Interesting role, and she's team leader in the health team on Mercury Initial Assessment Project, and she's been coordinator for the East African Dental Amalgam Phase Down Project. So active on a whole series of fronts. So Margaret, we really thank you for putting together your presentation for today, and we look forward to hearing from you. And I would ask everyone to put your speakers on mute. That would be really helpful to minimize the background noise. And some of you may want to turn off your cameras, although it's probably nice for Margaret to see one or two faces as she goes through the lecture, because I think it can sometimes feel rather strange lecturing to what feels like a vacuum sometimes. But we're here, Margaret, and very much looking forward to what you have to say. There is a chat function so people can put their questions in the side, but no need to look at those, Margaret, as you go through your presentation. We can pick them up when it comes to question times. So capture your questions, and we look forward to a creative discussion at the end of this session. So without further ado, Margaret, over to you. Please do give your presentation. Thank you.
Thank you. Thank you very much, Professor Jenny. Like I said, my name is Dr. Margaret Wandera, and I'm a Ugandan qualified dentist. So my presentation for today is an overview of infant oral mutilation in Uganda. The outline is I'll start with a description of what infant oral mutilation is, then I'll go on to the impacts, and then I'll give one or two slides about the practice in sub-Saharan Africa. Then I'll focus more on in-depth in Uganda, and then what is the global impact, and end with a few recommendations and the conclusion. So infant oral mutilation was first cited in 1932 in the Nilotic Sudanic tribes. That's the first mention of it in literature. And this is a procedure carried out in some sub-Saharan regions, Africa, in the belief that it's of medical benefit. And some people use it as a cure, some people do it as a prevention. So that's why I put it as it's done to prevent and or cure childhood diseases. It actually refers to a traditional extraction where they extract the unerupted teeth, and the age range you find in the literature is from 4 months to about 2 years. And what they extract is actually the tooth buds, which have not mineralized. And these are shown to the parents as the offending worm because of their soft appearance and their worm-like appearance, and they're purported to be the cause of the illness that the child is suffering from. And this IOM, this is usually carried out for various symptoms that are seen in children. But the most common that is reported is febrile illnesses and diarrhea and vomiting. But I have come across 2 studies where difficulties in breathing was one of the symptoms for which a group said they can also conduct infant oral mutilation. And what's important to note is that these are symptoms that are very common in childhood illnesses. And also this age group, 4 months to 2 years, is the age when a child is transitioning from a mother's maternal immunity. So they're very susceptible to disease. And I want to explain this, what the practitioners of the people who conduct this target the area of prominence on the child's gingiva. And when a child is sick or dehydrated, then the area of the canine tends to be the most pronounced. So those are the most targeted. And they carry out multiple extractions on the same date. So it's not one single extraction that is done, it's all the prominent areas. So you find they will go for 4 or 2. And most commonly, if it is only 2, it's the mandible that is more often targeted than the maxilla. And what you find is it may be a simple and non-intrusive, they may be doing something that is just like rubbing herbs on the gums. And in some instances, you find reports of just a little incision and then they rub herbs. But when it becomes more of a mutilation is where they have dug in with metal instruments, and I have a list there. And rarely do you find anyone talking about sterilization. I only came across two people who talked about heating or boiling of the metal instruments before they used them from one child to another. And this procedure is commonly done by traditional healers. And I thought I should mention who the traditional healers are. In Africa, these are usually just any member in the community who's accepted to provide healthcare, who hasn't gone for any kind of formal training. So when you read in the WHO reports, you find that over 80% of African people living in Africa actually report to traditional healers for seeking different kinds of medical care. And since these are people who live in the community and have grown up in the community, they're very accessible, and their terms in some instances also seem to be affordable as compared to formally trained. So they play a very important aspect in primary health care. So this procedure, considering the way it is carried out and the group is carried out on, I thought I should mention the adverse outcomes. There are those which, and this grouping is it's just the grouping I found that was more convenient for understanding. It's not like a standard grouping. So I grouped, when you go through, people give short-term, long-term, but I felt immediate and long-term would serve the purpose for the presentation today. So immediate is what happens as the result of the procedure. I've seen a recent study by Kimoli where a child died within 24 hours of the procedure. And this immediate may be because of excessive bleeding. I think in Kimoli's study it was excessive bleeding, but also there's the danger of the child having an underlying illness. So if it is mismanaged or there's delay for receiving management, the morbidity will increase in those children. And then, of course, the use of the non-sterile instrumentation results into all kinds of infections, and children have died from sepsis, septicemia, osteomyelitis, and tetanus. Then with regard to the long term, they're psychological, which I don't believe I'm equipped to discuss, but I can mention that like in future, because of the effects, some of the children may have some psychological effects. And then there's the dental-alveolar effects, which I can talk a bit in detail. And most of these dental-alveolar impacts are developmental because of the the procedure that is done and the time of development. So the list I have there reads like developmental anomalies. All these have been reported in the literature, and the list is not exhaustive. And from what the list I have here, you can know that the child will eventually need to show up for orthodontic care, or in cases where there's hypoplasia, the teeth are more susceptible to dental caries. And that's why from this angle, it should be of concern to the oral health community. And these are just a few images I have from the literature, where the first figure 1 and 2 are brothers, they're Somali boys. One has the cuspids missing, and the one in the lower image has just, you can see the surfaces of the teeth with the hypoplasia. Then I'm sorry, this 4-year-old on the right is not very clear, but had all 4 missing cuspids. Then this image is, figure 4 is a Sudanese boy. You can see the severe crowding, and he had history of infant oral mutilation. And then the image I have on figure 5 is just an example of where you can have the teeth peg-shaped, because, and then the missing central and displaced. So that shows you the severity of and the various ways the infant oral mutilation can interfere with dental alignment. I want to just mention the countries that, though a few of those images, you may have time to go back there, from all over sub-Saharan Africa. But these are the countries that actually you can read in the literature, have a lot of reports. There's Ethiopia, Somalia. I've put South Sudan and Sudan, but a lot of the literature was before the South Sudan had separated, so it may not be so much of the Upper Nile. Chad has been mentioned, the Democratic Republic of Tanzania, of Congo, Tanzania, Rwanda, Burundi, and Uganda. So I'll use this image to show where Uganda is. We usually like to say we're in the heart of Africa. So Uganda is a landlocked country situated in East Africa. We have 4 main ethnic groups, and for the people who are not very familiar with what an ethnic group is, these are just people who have a shared culture, language, and heritage. And in Uganda, we're very unique in that these are the 4 main ethnic groups, but if you search, you might find this, they might talk about 6, because the groups have again split into languages, and presently Uganda, I think, we're quoted as having 54 tribes. That means 54 different languages. And so these, but because I mentioned the ethnic groups, because the infant oral mutilation is purported to be spread by the nilotics. So we have a big group of the nilotic group. I'll show it in another image. And also I thought it's important to note that these, although these are found only in Uganda, we have artificial borders. These artificial borders were put in place during the colonial occupation. And Uganda is, I think, what's considered a young country. Will only be 60 in the coming year. We attained our independence in 1962. And we had a period of instability that is also important in relation to the infant oral mutilation. Between 1971 and 1980 was a period of instability in Uganda. So this is a map showing the current borders of Uganda, and the Nilotic tribes are mostly on the northern part, and the other, the Bantu, which extend right from Cameroon down to South Africa, and most of Tanzania is the part that in this image is seen as green. And maybe I'll just mention all the the tribes in white, those are different languages are spoken, the Langwa, Choli, Uganda, but they also have sub-tribes. So I know my tribe is missing in that list. So with regard to the infant oral mutilation prevalence in Uganda, there are still few studies, but I decided to pick up a few studies and put them in this table just to give you an idea. And you come across, the first time the word of mutilation was mentioned was in 1969 by Pinborg. That's the first time, and he mentioned that this was only done in the northern tribe of the Acholi, and the prevalence then was 16%. Then there are not very many studies that are purposely looking at this tooth, but I came across a study by Bataringa et al., a colleague who did this as part of her postgraduate studies, where she was looking at the effect of this practice, and she found 24% in adolescents in the capital city. And then I just thought I should mention Batwala et al., that's the third study in this table. They were looking at the oral health status just in the area of, of Western Uganda. And they came across canines missing in 2% of the children, and they realized that this was because of this canine practice. But the most recent study, which looked at a more national picture to see what was happening with infant oral mutilation, was in 2013 by Chiromo et al., and he had 6 representative districts, and defined the range from 17 to 55%. And just to know that this is something that is not disappearing, I thought I should mention the study that was done by Msingrizi et al., which found 8.1% missing teeth attributable to this practice. So this is from Chiromo et al. What is of interest is the ethnicity they took into account, and the Bantu have a significantly lower, that's the tribe that's found in the southern part, although 22% is still a high level of tooth bud extraction. It was significantly, lower than the nilotics or the nilohamites. So I just thought that it's important to answer who is doing this, who are doing it in Uganda. And it's, again, you find that in all the reports, it's the traditional healers. It's more than 50% of the times it's a traditional healer who has carried out the infant oral mutilation. And in some instances, they talk about elders, relative, and auntie and uncle. That's why I put elders and relative. Then you find traditional birth attendants. But more recently, it's coming up where there's some, they're saying trained health workers. I've come across some studies where they say trained health workers actually carried it out. So they may not cause a mutilation, but the fact that they may want to do something to give the mothers comfort, because the mother's expecting you to do something in the child's, the edentulous child's mouth, that raises some concern. And then I also came across this on YouTube. It's from one of our national, it's not a very clear image. It's a whole video, 5 minutes, and I knew we didn't have the 5 minutes to watch it, but it's talking about, it was shown on the national media in 2016, and it's talking about how the Ibinya are treated. That's what the local term for the disease is called. And it actually shows someone rubbing, I think, in this image, I think the child was having was teething, and so they're rubbing some substances there, because they explain that you have to rub very vigorously to treat the illness. So I just thought that this is as recent as 2016, so this is not something that has gone away. And then the comments, I saw it has more than 2,000 views to date, and then there were just 3 comments. So one which says thanks Jaja, which is the term for grandmother, generally in some parts of Uganda, and the person saying that's how I was going to lose my son. And then the second comment is just what brings revenue. And then the third comment is my daughter, Avelina, which means my daughter has this. So that was of concern. And I just thought I should mention something about the trends. In 1969, when Paintball recorded this, he recorded that it was only this Nilotic tribe of Acholi practicing it. And he actually, in his document, he alludes to it. Just let him document it because it's not going to be practiced. And that's the same thing that happens in 1971. Hallestrup is just documenting traditional practices, and he believes that these practices, he's documenting them so that people just know about them. But then in 1974, I come across Gom's report. He's a doctor, a professor in Makerere, who reports that this practice is spreading. And actually, in 1988, the Uganda Dental Association newsletter is completely about this. A report written by Dr. Rawal, I believe Rawal, and he was working in Eastern Uganda, and he talked about the Acholi people had spread this practice to this part of Uganda, and he was there was a challenge for the dental surgeons to educate people of this practice. And as we've seen in the previous slides, it has now spread to the whole country. And in the north, the practice, which was just 16.1 in 1969, is now over 50%. So I looked into why is this trend, what's the cause of the rising trend and the increasing spread. A lot of the literature, which is in the anthropology, I called it the anthropologist theory, is they blame it on the period of instability. So during the time of instability, there's a breakdown of infrastructure in the country generally. So people had to source for how to get treatment. So education and healthcare were in the decline. So this may have promoted the practice. Then what comes across that is also is the morbidity and what they're calling the morbidity and mortality paradox, because this age group has febrile illnesses as the most common cause of mortality. And in Uganda, we have a high mortality rate, although it has been brought down in the last 10 years from 90 to 48 per 1,000 children. The paradox arises from those children whose condition worsens or even improves after removing of the offending worms, because this is shown to the parent or guardian of the cause of the illness. So that's the paradox. How do you eliminate the belief that this is what caused the condition? And in Uganda, we also have medical pluralism. That is where individuals seek help both from the biomedically trained and the alternative or complementary or traditional healers. So that makes it a unique environment for how to address the spread. And I just thought it's important also to mention the workforce, because if the dental workforce is going to address the effects of IOM post the happening, we have a small workforce for population. I took the figures of 2018 because I do have a friend who's a colleague who's going to present the current figures. So I took earlier years because she's just been doing the current years. So in 2018, there were at least 400 qualified dentists, but those registered to practice were 286. And this is for a population of, at that time, 42 million. And these figures in the table as well are the specialists. So we do have a very low number of specialists. That the percentage you can see of orthodontists, 1% of all the licensed dental practitioners, restoration, 3%, and maxillofacial surgeons were only 3%. And currently at graduate level, it's only Makerere University giving oromaxillofacial surgery, although I know they're ongoing negotiations to have more postgraduates. So from these studies, we come up with some recommendations, which generally were about educate the general public and the traditional healers. That's generally educate the population on the dangers of the practice, and also to educate health-seeking behavior of the community. And so that they, because you'll even find some of the literature where they actually smuggle children who are in hospital admitted out to a traditional healer, where when the mother has lost hope, she does not see her child improving. So there's a back and forth movement between the traditional healer and the biomedical services. Then we have to improve the knowledge of the population on common childhood illnesses, since these practices are very closely related to the childhood illnesses, and also conduct further research on this infant oral mutilation to establish the actual population that practices. And I think that in that way we know how to move forward. So what are the eradication efforts to date? We have scarce reports, and so at present we don't have a national policy. But there's some, because of people's personal experiences, and some organizations have tried to set up interventions in ways of educating the populations. They set up videos, they have leaflets. But what comes out from that is you find instead you have patients coming closer to, within 24 hours of the mutilation, coming to the hospital, rather than abandoning the practice altogether. So I'll just have a few slides on why we should all be concerned as a global community. One is because of the dental patients. We have seen that there are more patients now who have undergone this procedure showing up in different parts of the world. And one of the reasons is the adoption trends. When celebrities like Madonna, Angelina Jolie started adopting African children, it kind of also became a trend. And there's a report where there's a rise of the total adoptions, international adoptions for Africa increased from 5% to 22% in 2009. I tried to find out if the figures changed. That's from the total adoptions done on the world scale. And then there's also immigration. A lot of the literature, even the images I got, were mostly from case reports done from these different countries. So now IOM has been reported in France, Sweden, Israel, UK, USA, Australia, Norway. And yeah. So, and then the immigrants also continue this practice in the adoptive countries. There's a very good study done on Ethiopian Jews, Ethiopians who had moved to Israel more than 15 to 20 years. And they looked at the adolescent children, and they found the practice in 60% of the, I think it's 60% of the adolescents had undergone it. The ones who had parents who had settled in Ethiopia for more than 15 to 20 years. So that's also of concern. Then there's interdisciplinary collaboration. When you're looking at this subject, you find it across all disciplines, so many disciplines, a lot in sociology and a lot in anthropology, not so much in the medical field. It seems to have a more cultural, social interest. So I think it's important for us to have that, to engage the different disciplines. And I have here a list of the names that it comes up. So when you put in a search word, you may not find infant oral mutilation. And I just thought I should highlight the last two. Evinyo, we call it Evinyo in the region that I'm in, but they're different spellings. But in Uganda, those are the most two common that you find used. But there's a whole range of words that are used. Then also why the global community should be concerned. It's always good to have cultural competence, to be aware of what other cultures are practiced, and have this just as part of your, let's say, arsenal, to be aware, and so you have the right attitudes toward the different practices that exist in the world. And just thought we should learn from the past experience where we had with FGM that's spread widely before it was recognized or addressed. And there's always value, of course, in sharing knowledge, because this is an effective channel for partnerships and developing research, and maybe also to access training opportunities. And we need to really have a targeted policy towards the elimination of this practice. So in conclusion, I believe to eliminate the practice of IOM, we need a concerted effort that understand what sustains the belief in the practice. We have to improve our community health education and improve our health literacy of our communities, and improve the child access to health care, and develop appropriate policies that include associated elements, for example, to address child abuse. This somehow comes up because these children are not consenting. And I'd like to commend the organizations like Dent Aid who have this activity. They have some activities that are going on in Africa, and then I also came across the East African dental community who are trying to seek ways of ending this practice. And I appreciate Global Oral Health Inequalities Research Network for providing this platform for us to talk on this urgent childhood problem. And we encourage and welcome all efforts aimed at eliminating this practice of IOM. And I'd like to thank you. These are just some references I used, not exhaustive, but what I could squeeze onto the slide. And I'd like to thank you for your attention.
Margaret, thank you very much for a very clear and challenging presentation. You know, it is really good to see you providing an overview of these challenges and reflecting on how they can best be addressed. So time for a bit of discussion and debate. I would say it's my first experience of it was as an undergraduate student, because I spent a summer in DRC. It was then called Zaire, but it was just on the sort of western side of Lake Albert, and therefore that was the first time that I came across you know, adults and children with these gaps, and I knew it was part of custom and practices, but it's been really illuminating just to hear what you have to say today. So who would like to kick off with questions? There's a couple in the chat. So one about building dental capacity by training nurses and midwives within the current educational model to give preventive education with moderate treatment. I don't know whether you can see that and you'd like to comment on that question and respond to it. So, you know, how can we build dental capacity? Because you've outlined the challenge in terms of dental capacity.
Again, that would go back to policy and partnership, because what has happened with when you train, maybe you train them just for examination, it's a bit of a hard line to draw about limiting what they can do, because they don't usually look into the oral cavity. What we find working with them is they don't usually look into the oral cavity. So that's like a gap that the traditional healers have exploited. So the group of children we're looking at are the edentulous. There are a lot of balls in the air with how to carefully. These are children who don't have teeth. So encouraging a midwife to look into an edentulous child's mouth. That's what we want to take away. We don't want them doing it. They have no business in the mouth at that point. So it's one of those.
I wonder what's in there.
Answered the question.
Yeah, I wonder what's, just staying on that point, I wonder what's in their educational program about managing sort of early childhood illnesses in that period when they're losing their, in a sense, the innate immunity that they're born with, in that sort of transition, what's what sort of education do they get about how to manage it? Because it's one thing telling parents, you know, this is not a good idea, but actually if they have a child with whom they think has got a health problem, actually, what I wonder what is part of the nurses and midwives and other healthcare professionals' education in terms of managing these childhood illnesses.
One,
So we have
one
to
thing,
offer parents.
one thing maybe I'd say is because we are a malaria endemic country, so febrile illnesses is at the top, and then pneumonia is also one of the top 5 illnesses. So they are very good at recognizing, even the community, the village health. We have something called the village health team, so they can recognize those children and direct them to where to receive care, and they can give the first primary health care with regards to treating malaria. But the fact that we have a traditional, these are not, I mean, it's not like this, these are just normal community members who can find you with a sick child and say, that child needs this treatment. And then your child's life depends on that decision. So it is that environment in which you, let's say, like break from the norms that you're trying to get in. So there's the idea, the challenge we're having is how to delicately get into this, that environment of a young child. It's still a lot of things to work through.
So I'm going to pick up on the sort of Uganda specific questions for the moment, and then I will pick up on the sort of more global ones. So people have got want to ask a question out loud, please do. Otherwise, I'll pick the ones up in the chat. So the next question sort of follows on. Is it allowed to talk about this in Uganda as a problem? You know, even amongst health professionals, you know, how much is it actually talked about, or is it such a societal norm and a cultural norm that it's almost taboo to raise it as a problem or a concern?
That's a hard question to answer. We know about it. We talk about it. It's not under the table. Like everyone talks about it, but the problem is because what the practitioners do is so varied and various in the different regions. So it's some who are just putting herbs. So it's someone who's just rubbing herbs is not as crude as someone who's going in with a bicycle spoke. So we need to, what we don't have is the actual picture, like the country picture, who's doing this, so that you can have a targeted. So that's what the organizations have done. You find one who was so frustrated because they did go in and educate, and they made leaflets and had videos, and they do have a trend of less people coming in. I think it dropped like from 40% to 8% of children coming in having had this procedure. But then they were confused about what they call that a success. I think that's, I can't remember quite clearly, but
I think compared to some of our interventions, that sounds pretty good. Depending on the numbers involved, but I wouldn't be put off by that. So one of the other questions here is the practice of infant oral mutilation socioeconomically patterned? You know, is it more likely to be in lower socio-demographic groups in society, or if we take that one first of all, or is there enough evidence?
The question
to
is it a social? If it's a social,
yeah, is it
socio-economic?
Yeah. Yeah.
It appeared to be in some communities to be more, but then more rural than urban. But then it's not. You don't find it very significant. There'll be some societies where it's more, where they fear them to lose the male child more, so you'll have more of the male child than the female. So it's at presently it's the demographics are so different depending on where your study is done. So like you go to the slums, it's compare it to the educated, you get. But it's not yeah, you don't have significant numbers.
Okay, thank you for that. And is it a next part of that question is it coupled with any other practices harmful for general health?
Is it?
Are there any other harmful practices going on in parallel? Are there any other procedures or practices at the same time to deal with this childhood illness or prevent childhood illness?
Interestingly, the two papers that I mentioned, the one of Pinborg and Hallstrup, who had tooth sharpening, and those died out. Those don't exist anymore.
Ah, interesting.
Yeah, those are not practiced anymore.
Interesting, because I saw quite a bit of that. Interesting. And then another question, are there any ethnic community members available for participation in health promoting activity or even evaluative research, sort of actually using local members of the community?
We actually have a very good, it's called, it's abbreviated PITA. I can't quite recall it now, but it's something to do with traditional health. The Ministry of Health is partnering with the traditional health workers. And but what I found, because I actually have had a conversation with a couple of the leaders. I know two leaders in the of traditional healers. So this is a conversation we have ongoing. But most of them, what Ministry of Health is more interested in is the herbs, the medicines that they use, which are effective, what is the active ingredient. So somehow this practice, which is invasive, is not like really, they were surprised. They were actually also saying, oh yeah, we think people do it in our community, but we also want to know why they do it, because they don't actually, the people I know don't actually do it. So they're also like on my case knocking, what do you know? What more do you know? And so we do have an open conversation, but no one knows why this practice is, why it's perpetuated in the community. So it's, I think if we come up with the language that the traditional healers can understand, if we educate them in the way they can understand, then they can be a very good component to address it.
And there's a question as to whether the Ministry of Health has made any recommendations in their policies towards IOM. You made a statement about needing more policies. Has the Ministry of Health made any statements?
We have general oral health policies, but it's not like it's targeted. It would be just like it would be like the child abuse. It wouldn't be something like stop the practice, because in Uganda, maybe I should also mention, it has so many names, and the different names also give it different connotations. So it's very easy for it to slip under without.
Sure, thank you for that. The next question is from Peter Mossy, and he's got several he wants to ask you, so I think he wants to come online. Pete, do you want to come in and ask your questions? Thank you.
That was absolutely fabulous, and in fact, many of my questions have now been kind of answered by that discussion. But there's a couple of things I was curious about, Margaret. The infant mortality is still fairly high, and febrile illness seems to be one of the main reasons why this practice is still prevalent. And it was a bit worrying, actually, in your Taromwe paper in 2013, that there's still, such a high prevalence, 17 to 55%, or depending on tribe or ethnicity. But if there was better access to medical care and medicines, where people could access, the traditional rather than the traditional, the medical care. Do you think that would make a difference, or is it so ingrained in society and so much a belief that it's beneficial that might not work? What's your thoughts?
Now my thoughts on that is because it's having interacted with the different communities that have this practice, usually find it doesn't go back more than 2 generations. You find a grandmother has never heard of this practice and she will not accept it done on her grandchild in some areas. So in some areas, it would may be very easy to turn back because in fact, the children who are reporting to dental clinics before the procedure are usually brought by grandmothers. My colleagues, the dentists in Uganda, have had that experience where it's a grandmother, so it's people in the grandmother's age who have never, so those areas, it would be very easy to turn back. But in the areas where it's now 50%, it may be a different kind of, because it may be more established. But where it's still below, where it was an incidental finding where they only found 2% of the population, it may be very easy to turn back because that means maybe just a small community brought it in and they don't really believe it, but it's an attempt of saving a child.
Okay, and my kind of last, or the other question was, as Global Oral Health and Equalities Research Network consider ourselves to be action-based, we want to do what we think is best. And what do you think would be the best way to target the problem? Would it be to, for example, address it in the tribes where it's most prevalent, or do an upstream approach and try and approach it from a higher governmental level, or is it the downstream actions? I mean, I'm just wondering, kind of next steps.
I think it would. I would prefer you approach it from that's downstream, from the ground up here. So because we really have to understand what is sustaining the practice, and it's because it's a belief, it's a cultural norm. So that's the area, because once you come up with I know in Tanzania they did outlaw it in I think the 1980s, because actually the literature, it says it spread from the I think Tanzania and Kenya, it spread from Uganda. People who fled the country came with the practice and then it was adopted there. So they outlawed it because it was a foreign practice, but then what happens, it actually goes under. So it becomes harder for you to eliminate the practice because the people who continue the practice now become shadows. So it's the preferable approach to me, I think, is understand what the drivers are of the practice and then address it with what information you gather in that way.
Very good. No, I agree. Thanks.
Thanks, Peter, for that. And I think that sort of really underlies the importance of listening to the communities and recognizing that there may be other aspects of healthcare. And I think you mentioned the cost issue, as well as, parental concerns for their child, the challenges of cost and easy access to traditional healers, etc. And mapping that out is, as you say, important in research terms. And I think linked to that, Lois Cohen has asked, are there lessons to be learned from FGM research, and has anyone looked at that literature in relation to this? I suspect you have, Lois, if you want to come online and make any comments or suggestions, but I'll let you, Margaret, just sort of say your piece. So anything to be learned from how FGM has been managed in your country?
No, that's a whole lecture. But anyway, let me see what I can. That's a whole different lecture. But there is something to learn. But I would be very cautious because with FGM, I think what our take would be just the cultural competence, know that there's this practice, and but because this group of, these are children, they're non-consenting, they're very vulnerable. So, and then the mother is doing this to say, the parent is, or guardian is doing something to save the child's life.
Yeah.
So while on the other hand, FGM is about the future spousal relationship. So distinctly different, but both cultural practices. Yeah.
Thanks,
Because
Margaret.
across FGM, there's some ladies who requested because of the cultural belief. So, but these are children who were mutilated without, and have no memory of the mutilation. So they just show up and they have this effect.
So if I may,
Please, Lois, thank you.
Hello.
can I respond a little bit? I think, Margaret, thank you. This has been so stimulating. And I do remember Jens Pinborg's talking about it and actually visiting various countries in Africa. And I heard different stories about what this actually means culturally, ethnically. And maybe in one culture, they think it's worms, but in another culture, they're preparing the child for adulthood and some interaction in that context of adulthood. I have a feeling, at least in my head, of imperfect meaning. And I brought up the female genital mutilation literature, mainly because what you said, the anthropological cultural meaning. In order to reduce it, we really have to try to understand from inside the culture. That's why I also asked that question about, are there any members of these communities that can be engaged in a more in-depth, focused way to extract differential cultural meanings and get at that level? It's sort of the anthropology of it. We're giving Western medicine kind of views, biomedical intervention views, and I just wondering whether that's okay, but it may be insufficient to bring down the negative behavior.
Can you hear me on this call? Can you hear me?
Yes, is that Brian Swan? Hello. Yes,
Yeah.
we can hear
Oh.
you. Thank you.
Yes. I was just wanting to point out, I think that you raised a good question, Lois, but one of the things I wanted to say about Uganda and relative to how they dealt with HIV/AIDS, you know, they didn't have necessarily a lot of the resources that we may have in the West, but the ABC technique was abstinence, be faithful, and use a condom. That went throughout the country, including traditional healers. It was culturally sensitive, and it was extremely effective in a relatively short period of time. So, you know, thinking about that type of messaging and understanding relative to the resources that are in a particular location, I think is an extremely valuable way in which we can curtail certain types of behavior. And we found in that particular instance, in talking with Maggie about it, is that the cultural healers were very receptive to learning more about how to prevent, you know, these particular diseases.
Margaret, do you want to come back on that and pick up on it? Because as you've identified, these are mothers who've got children that may well be unwell and are endeavoring to do the best for them at that point in time. And then I see Christina's got her hand up. We'll come to you in a minute.
Christina's hand has been up for a bit, so
yeah.
Yeah.
Okay, I'll just quickly go. I think you actually covered what I was going to say. And Thank you so much, Margaret. I was really looking forward to this talk, and you did not disappoint. It was excellent. So I'm just, it's about the FGM discussion. I think when you look at the discussion in the UK with immigrants who've come in, there are very many powerful stories from people who actually went through FGM. I think that has really pushed the agenda, creating a very clear picture. And as Margaret said, these are children who won't remember what happened to them. So this is very much a child protection issue, in my opinion, because who's going to speak about how awful it is? We're just imagining it. Many of the children who go through it might just think they have crowding because they have crowding. And the ones who died, of which there are many, are not here to tell us the story. So I think the approach here is, this is really like a child protection justice type of situation. That's all I want to say.
Thank you, Christina, for that. And it opens up another interesting angle in terms of research with people who have moved to adult age and have missing teeth. Actually, how did they feel about it? Because they might well be, the survivors may well be advocates for change.
Oh, yeah.
And is that an area that, you know, coming back to think, well, actually, what are the things that we can do within GOHIRN to support you in answering that bigger picture question, which Brian posed at the very beginning of the sort of chat? How can we help? And, you know, in various ways. Any suggestions on what help we can provide, Margaret?
I think at the moment, because this has been a very low, a very hidden fruit, let me say, for research. So yeah, we've sent out multiple, I'm sure Professor Kimoli is with me on this one. We've tried so many ways of trying to get funded to look into it, but it's not one of the areas of interest. So we really would like to get the picture, to profile what's on the ground, and then we will know which way to move. Because of course we'd like to have it in the curriculums. The pediatricians are actually, they're the ones who are getting the brunt of it, because I had the experience having to, when I was collecting my data for the PhD, to work with, because I was looking at pregnant women, so I was closely working with pediatricians. So we found that they see the patients and they're concerned, and so if it was something that was in the curriculum across board, so the pediatricians know about it, the oral health practitioners know about it, would have a way of working together. And the skill set, we do need the sociology, cultural aspect to know how to enter these communities. So it's a kind of a big, the help we need is mostly in the access to research, funding, and also the experience, based on the experience people have working in similar situations.
Thank you, Margaret. There's a couple more hands up, but I'm aware that we're getting to our time limits. So if you could probably both, there's Arthur and then Edikina. Edikina, would you like to go first? And then Arthur, just quickly give us your questions. We'll take the two questions together and then give Margaret the last word.
I think Adeyinka.
Adeyinka, sorry, my apologies.
Yeah. So no, that's fine. Thank you. I'm Adeyinka Dayo, and thank you so much for that presentation. It was very informative. I actually originate from Nigeria, so I'm kind of used to such situations. But right now I'm in the US. My contribution or comment is that at the upcoming IADL conference, is there a way that we can actually have like a small session or something that we can kind of create awareness about this, since it's, you know, international, all people from different countries are coming in? It might be a good way to kind of like, you know, make awareness for them, so that in case they see these kind of situations in their countries where they practice, they might be aware of it. Thank you.
Thank you, Adeyinka. And Arthur?
Okay, thank you very much. I do not have a question. I wanted just to compliment Margaret on the work she's doing on IOM. I have been involved in it. I'm still involved in it. And I think she knows what I've been doing and what I'm doing. And to emphasize on the fact that this is actually a global issue now, because we have got all these people from the areas where IOM is being practiced, and they are migrating, translocating themselves to other countries. And that's why we have had case reports coming out from Australia, New Zealand, Canada, US, in Europe, whether it's Scandinavia countries and so on, Denmark and so on, even in UK. So we need to have concerted efforts in doing this, just like FGM has had grip in doing this. And it is all about public education. And if we can come together globally, plus influence the policymakers so that we have policies put in place, legislation, like FGM has done, I think we'll be able to tackle the problem.
Thank you, Arthur. Where are you based at the moment as you talk to us?
Oh, my name is Arthur Kimoli. I'm from the University of Nairobi. I'm a lecturer there in pediatric dentistry. My rank is associate professor. So that's what I'm doing. And I have been also doing a lot of connection with other people on this issue.
Fantastic. Thank you, Arthur. So, Margaret, would you like to make any final comments?
I'd like to thank Global Oral Health Inequalities Research Network for giving me this opportunity. It's something I'm really interested in, infant oral mutilation, and I feel if I have more people on board, we're making progress.
I think that sounds fantastic, and I liked the challenge as well about raising it at IADR, and I wonder whether we say, right, let's commit within GOHIRN to support you in this, and perhaps in the 2022 meeting to actually have a full symposium on it. And I wonder whether, you know, a number of us can sort of support you with some extra research in the forthcoming year that actually then could be presented on that particular occasion. So I think that leaves us with a challenge, and as I think I will be the incoming president in 2022, so of this particular network within IADR, perhaps we pick up that challenge at a future meeting and support you in doing that. I think it's been a fascinating topic, and we could keep going, but I'm going to keep faith with everyone and say we need to draw this really interesting and important meeting to a close. And I would like to thank each and every one of you for being here. I'd like to thank you for all your questions and contributions, and above all, Margaret, for a very clear and thought-provoking and important presentation. So I wish you all a very good day, and thank you, or a good evening, depending on where you are in the world.